So now on behalf of the UC Davis Pre-Health Student Alliance, I want to introduce you to our keynote speaker, Dr. Loel Solomon, the National Health Director of Community Health Initiatives
Thank you.
and Evaluation at
Too
Kaiser
kind.
Permanente. So in this position, he works with other health plans and medical group leaders to establish the strategic direction for Kaiser Permanente's multifaceted approach to prevention and community health. And he also develops national partnerships to advance those ends. Since joining the program in 2003, he has been responsible for a national effort to improve health outcomes in Kaiser Permanente's communities by focusing on environmental and policy change. Prior to coming to Kaiser Permanente, Dr. Solomon served as Deputy Director of the California Office of Statewide Health Planning and Development for Healthcare Quality and Analysis, where he oversaw the state's hospital and outcomes reporting program, analysis of racial and ethnic health disparities, and discrimination of healthcare data to researchers and members of the public. He received his Master's of Public Policy at UC Berkeley and Ph.D. in Health Policy from Harvard University. So please join me as I give a hand to Dr. Loel Solomon.
Thank you. And as Alvin brings up a few slides here, I wanted to say hi, welcome. It's kind of early in the morning. Shouldn't you all be asleep or something? No. You're hardworking and dedicated and all that. So it's a pleasure to be with you today. And it's great that we have an intimate group. I did have some grounding slides that I wanted to share with you, and then kind of leave a little bit of time for us to have a give and take and have you respond with anything that you want to, any questions, anything that I provoke you with. But as Alvin said, my name is Loel Solomon, and I have the best job in health in America because I get to work for a very large integrated delivery system called Kaiser Permanente, which many of you, at least you from California, might have heard of. So we are a bunch of physicians, and we've got 37 hospitals. Come on in. And 9 million members. And the cool thing about Kaiser is that we have, how do I advance this here? Okay.
Maybe I could just do it for you.
That's okay, I'll do it. So the cool thing is that we have a commitment to prevention and to public health, and working in a healthcare organization that is committed to public health allows us to do things that are really exciting and interesting. And the reason that we're committed to public health, and you'll see this in the perspective that I share with you today, is because our doctors and hospitals get a payment at the beginning of every year, essentially, so that we've got an economic incentive to take care of our members and make sure that they're as healthy as they can be. That saves our system money, it saves our members money, and it creates a kind of incentive that is really at the heart of what people think about when they think about healthcare reform. And I don't know if you read the paper, if you hear about these accountable care organizations and different ways of doctors and hospitals and health insurance companies working together to improve care. That's kind of been embedded in our DNA for the 45, 50 years that we've been around. And we actually started off in the shipyards in Richmond and at the Grand Coulee Dam and some other big construction projects as a clinic that was part of an employer. And our job was to take care of the employees and then the families. And so it's a very kind of unusual place to see the change in the healthcare system. And that's the perspective that I come at this today with. If any of you are reading the paper, you know that everybody is talking about Obamacare and the Affordable Care Act. The exchanges went live on October 1st. The healthcare reform is at the center of this current stalemate around the federal budget and the closure of the government on October 1st. Everybody's focused on healthcare reform, and there's such a focus on that as a critical juncture for the American health system, and it really is an incredibly exciting time. For many of us that have been wanting to see healthcare reform happen for a long time, it's incredibly exciting. And in my former life, Alvin didn't mention it, but I used to work on Capitol Hill. I used to work for the Senate Health Committee and for Senator Kennedy, who passed away a number of years ago, who was the lion of healthcare reform. And many people worked on his staff and other staffs for years and years and years trying to make this happen. This has been an elusive dream. And here we are on the precipice of enacting universal care for folks. And the big question, I think, before us is, how do we not just deliver health care to 40 million Americans that currently don't have them, that the Affordable Care Act will extend insurance to, but how do we really deliver health? Because health care reform, the way we've currently talked about it, is about getting people access to doctors and health insurance and care when they're sick. And the real question for health reform and the real question for public health is, how do we make sure that people are healthier, that they come into the system healthier? And if we don't solve this problem, we are not going to have an affordable healthcare system. We're going to bankrupt the country, and we're not going to really live up to the promise of health reform, which is to really make sure that our population is healthier. And healthcare services are necessary, but my central proposition today is that it's necessary but insufficient. And it's really the job not just of doctors and nurses and PAs and allied health and people that develop drugs and other kinds of therapy. It's really the job of public health to take that broad perspective and make sure that we got a system that's keeping people healthy. So that's what gets me really excited, and I think that's the job for all of us. The reason that this is so important is because medical care is a tiny little cog in the system that produces health. There's been some really great research done that shows that medical care really accounts for only 10, as much as 20% of health outcomes for the population. The real drivers of health are genetic composition and those kinds of factors, which are very difficult to control. But the big cogs are personal behaviors and environments that we live in, and social factors, and in particular the interaction between the places that we live in, our environments, our surroundings, our social networks, the influence of our peers, and behaviors. And it's that interaction which is really the most exciting part of public health to me, and the opportunity to drive health by influencing our environments, influencing social norms, and ultimately driving behaviors that are really at the root of health. There's something called the actual causes of death, which a couple of researchers named McGinnis and Fahey started looking at going back 25, 30 years, and they've updated it a few times. And you know, when you think about the causes of death, you think about cancer, heart disease, things like that. McGinnis and Fahey did something really interesting. They tried to back it up and say, okay, what are the factors that actually drive the diseases that cause death? And they looked at it, and they found these actual causes are the major contributors to mortality in this country. Tobacco tops the list. 20%, a little less than 20% of the actual causes of death are attributable to that. And then right under that are poor diet and inactivity. And if we were to do this survey again, we'd probably see that diet and inactivity are battling with tobacco as the actual causes of death. And then there's a whole bunch of other things here. The point is that it's really these behaviors, smoking, what we eat, how much we exercise, whether we drive safely, what we do with firearms, things like that, that really influence our life expectancy. The United Nations and the World Health Organization have had a summit about 3 years ago on non-communicable diseases. And they're really focusing on these 4 modifiable risk factors, these 4 behaviors around diet, inactivity, tobacco, and harmful use of alcohol that contributes to these 4 major chronic conditions that drive a huge percentage of mortality and morbidity in this country and across the world. 70% of US deaths are attributable to these 4 factors. Another piece of evidence that's consistent with the McGinnis and Fahey study. Most importantly, from kind of an American economic competitiveness standpoint, we know that people that are able to have these healthy behaviors are half as expensive to provide care for than folks that don't. So there's a big economic driver too, but we're focusing on these modifiable risk factors, and the question is, what can we do to help people have these healthier behaviors? And I want to give you a little bit of a flavor for what one of the biggest non-communicable diseases are that is at the root of many cancers and heart disease and diabetes and some of these other things. And it's obesity. And obesity is something that I spend a ton of my time on. And I think arguably it is the nation's biggest public health crisis. And I want to show you a little bit about what's going on with obesity and how we back up from obesity and the medical issues involved there to more of a public health approach, and why we can't solve obesity through doctors and drugs and things like that, and how this is really an important battle for us. So I'm going to show you a few slides. Have you guys seen these maps that the Centers for Disease Control has done? A few of you are saying yes. I wanted to just give you a little bit of a flavor for how quickly this epidemic has rolled over the country. So this goes back to 1985, and it shows states where we have large percentages of people that are obese. And in this map, the dark blue is 10 to 15% of that state's adult population is obese. I'm just going to take you through the years and show you how over a 20-year period of time we've seen this epidemic happen. So this is 85, 86, a few more states. 87, 88, 89, 90, more states have a larger percentage. They added a new color in 91. More states are getting more obese. They added a new color in 1997, 15 to 20% of the adult population obese. More states getting obese. They added a red color in 2001 that shows between 20 to 25% are obese. More states becoming obese. They added a new color, 25+%. And here we are in 2010, with the Southwest having 25% plus of the adult population being obese. You could see how widespread this is and how quickly it happened. And from a medical standpoint, people that are obese have a much higher risk of all of these health conditions. Every organ system is really affected. And it is on the pathway to so much cost, so much pain, so much difficulty here. And one of the most significant consequences of obesity is diabetes. And there's a similar set of maps to the ones that I just showed you that show the increase in diabetes prevalence over the last even 10 years. And one of the things that's so disheartening is that for adolescents, we hardly ever saw kids that were diabetic. And over the last 10 years, we've seen a doubling of kids who are diabetic and pre-diabetic. And we really don't have any basis to know what the implications is for a kid who's 15 years old who becomes diabetic, and what happens to them when they're 20 or 25 or 30, and what the burden is on their system. So it's quite a significant issue from a clinical perspective. But the point that I wanted to make here is to kind of do a little bit of exploration and try and understand what is going on with obesity and some of these other non-communicable diseases, what's really driving it, and how do we get in front of it. So these are some GIS maps that Kaiser Permanente produced, and this is showing hotspots, geographic concentrations of disease for Kaiser Permanente members in the Bay Area. So that's the San Francisco Bay, and you could, for those of you that are in this area, that's the East Bay, Oakland, Davis is way out here, and San Francisco over here. And you can see these darker places are neighborhoods where we have higher rates of childhood obesity compared to the average in the area in this panel. Over here, you can see it's the same neighborhoods that have this higher prevalence of diabetes. And you can see over here, those are the same neighborhoods where we've got poverty and fewer percentages of the population that are getting their high school diploma and things like that. And what's important to show here is that these, especially in these first two panels that show these non-communicable diseases, childhood obesity and diabetes, these are Kaiser Permanente members. These are people that have the same health insurance, the same access to the same doctors, the same hospitals, the same drugs, the same kind of clinical experience. And still there's these huge variations in their health status and the disease that they're struggling with. And it's related to socioeconomic conditions and per capita income and some of these other things. So I think these maps really show that if we're going to address things like obesity and diabetes and other non-communicable diseases that are driving so much morbidity and mortality and so much expense and making our businesses uncompetitive and causing healthcare reform to be a challenge to finance over the long term, we really have to get underneath the disease and get out of our medical office buildings, get out of our hospitals, and figure out what's going on in our communities that's driving this kind of problem. So the question is, what is going on? And I want to take obesity as an example, and just an example. So what are we up against? As you remember, the two major drivers are, for obesity are eating behaviors and our physical activity behaviors. So I want to talk a little bit about what's going on in the physical activity environment that's driving inactivity, and then I want to talk a little bit about food. So we all live in communities that are either easy to walk or not easy to walk. We live in homes that are either really far away from parks and our ability to walk to grocery stores and walk to Main Street. And over the last 25, 30 years, we have seen these kind of sprawling developments where we really have to drive everywhere. It's really hard to walk to school, bike to school. Our communities are set up so that it's really dangerous, difficult to not be in our cars for most of our trips. We live in a sedentary environment. We've designed physical activity out of everyday life, which is really kind of the major driver from a setting standpoint. And when we're kids, we spend a lot of time indoors, having sedentary life, and then we get our jobs. We're working at desk jobs, and that's really different than it was 25, 30 years ago, where our jobs allowed us to walk around a lot more, where we walked around and got a lot of physical activity by accident. And a lot of times when we think about the inactivity crisis in the country, we think, well, people aren't going to the gym as much, people aren't working out as much. And the real driver at a population level is the kind of activity we get by accident every day on our way to work, on our way to school, and whatnot. So we're looking at these physical activity environments and finding that they're really not conducive to walking and to biking and to being physically active as part of everyday life. There's a very strong correlation between how much time you spend in your car every day and your probability of obesity. And this shows kind of the regression lines for those of you that have taken biostats that shows the relationship between obesity and the minutes spent in a car. And if you look at a lot of Northern European countries, you know that the cars are not a major way that people get around. In Holland, almost half of people use biking or walking on for their everyday trips. And of course, in America, that's very not the usual way that people get around. And so there's some important alternatives. But the more we bike and walk, the less heavy we are. The more time we spend in our car, the more heavy we are. And it's more complicated than that. In a lot of the communities that Kaiser Permanente works in, where obesity is the biggest, those red spots on those maps that we showed you, physical activity is at a low, and it's not appropriate to recommend to our members or the folks that we're working at the community that they walk walk to the park or get more exercise, because a lot of the neighborhoods that our members live in are not safe, and violence is a huge issue. So we work with community collaboratives, and we talk about what the barriers are to people being outside, getting out from in front of the TV screen and playing in the street. What we hear a lot about is how unsafe things are, and how people don't feel comfortable letting their kids play in the parks because of gun violence and other kinds of violence. And I'll give you an example from a community that's about 15 miles away, where we've been working with some public health folks and neighborhood groups. It's a neighborhood in South Sacramento called the Valley High area. And there was, we've been working with this obesity prevention collaborative for a number of years now. And one of the things that they were trying to do is to address traffic safety at this park. And this park happens to be a place where there's a lot of gang activity. There was something called a walking audit that the community was sponsoring about a year ago to address some traffic injury issues around this park. So there's a bunch of citizens that got together with some public health folks, and they're doing a walking audit at this park. And while they were doing the walking audit, this gun battle broke out. There were these shots fired, and the community collaborative realized that in order to address walking and trying to get people to use this park more, they had to address gang violence, and they had to address gun violence. And so the collaborative shifted from a focus on physical activity to a focus on gun violence and gang violence, and work with the police department, work with some community groups and some churches. And this is kind of one of the lessons of public health. You got to really listen to what the community needs and wants, and be ready to pivot and go where the energy is and go where the needs are. And so in a fairly short period of time, this community collaborative pivoted and started working on some violence issues that were really the most important issues for the members of this community. And within a short period of time, they were able to take back this park and put a lot of great programming in there, drive the gang members out, and give these kids something positive to do. So now there's a basketball league that runs a couple days a week there, and it's a great success story. And the road to obesity prevention went through violence prevention in this particular community. So on the food side, we kind of know what we're dealing with in the food environment. We know that healthy food is often hard to get. It's kind of expensive, and the unhealthy food is ubiquitous. It's completely around us. It's at every convenience store, every fast food restaurant. It's cheap, it's tasty, and you know, you could resist anything except temptation, right? This is what many of our communities look like in terms of the food environment. Fast food is all around us. And we ask people to eat better and just, you know, eat more fruits and vegetables. This is what we're contending against. In a lot of low-income communities, there are these things called food deserts, where you got a corner store, maybe a fast food restaurant, and this is what's in the corner store. This is actually a picture from one of the communities that we're working in Denver, in Park Hill, Denver. This is one of the captions that one of the residents put to this picture. Where are the fruits and vegetables and baked bread? Neighbors in this part of the community need some affordable and healthy choices in their local convenience stores. So we have fast food all around us. We have convenience stores that don't have fresh fruits and vegetables. If they're there, they're pretty skanky. Our kids are going to cafeterias that have a bunch of beige and brown foods. Things are getting a little bit better, but it's really, really slow. You know, for kids that go to that use the school cafeteria, this is what they're facing. And kids get, you know, 50, 60% of their total calories in school cafeterias. So school cafeterias are not necessarily a healthy place. And then let's talk about advertising. Because it's one thing to have healthier food around, and then you got to think about what the messages are that we're getting and what is incenting demand. And, you know, the food industry says that we're just giving people what they want. They want fast food. They want, you know, kind of the kinds of stuff that we're selling. And of course, we know that demand doesn't exist kind of outside of the advertising environment. And there's ways that industry induces demand, and they do it through billboards, they do it through digital advertising, they do it through price, promotion, product, the 5 Ps for those of you that have taken business classes. This is a real photo, obviously, taken in Oakland, California, a couple blocks from my office. And you can see the relative sophistication and you can imagine the budgets of the California Department of Health that has the top billboard and the organization on the bottom that has the advertisement on the bottom. Folks that are trying to promote healthy food are frankly outgunned by folks that are trying to sell unhealthy food. A couple years ago, we looked at the advertising budgets of the fast food industry. $40 billion spent by the fast food industry. The organization that sells the 5 a day message, 5 a day, fresh fruits and vegetables, produce for a better America, $4 million. $4 million versus $40 billion. So we're terribly outgunned. And kind of going one step back, we got to look at the policy decisions that shape the food environment and the physical activity environment as well. And this shows the food pyramid that is recommended by the USDA on the right. This is what the federal government says that we should be getting to have a healthy diet. And on the left is the federal subsidy dollars that go into each of those pieces of the pyramid. And you can see that most of your tax dollars go to subsidizing corn and other commodity crops that mostly go to these concentrated animal feeding operations that make meat really cheap and grains really cheap. There are no direct federal subsidies that go to fresh fruits and vegetables. It all goes to corn, soy, and then through those to the meat and poultry industry. So is it any wonder that we have a fat country and that we have obesity? And it's policy failure and it's challenges at the community level. And this is the challenge of public health, is to really go upstream and not treat people one diabetic at a time, one retinopathy exam at a time, but to really go upstream and ask what is driving the big epidemics in this country. And that's the role of public health. This just shows the impact of prices that our consumers see because of those subsidy payments. And you can see sugar-sweetened beverages have been going down over the last 30 years, and fresh fruits and vegetables relative to other prices have gone up. So we could talk about individual responsibility and individual choice all we want, and people are responding to availability and they're responding to price. So the Institute of Medicine really hit the nail on the head when they said that it's unreasonable to expect people to change their behavior easily when so many forces in the social, economic, and physical environment conspire against such change. This is the mantra that I think those of us that care about the nation's overall health need to really pay attention to. And this is the central premise of public health, focusing on changing these forces. So there's a lot of things that are happening in a lot of quarters to address obesity through community strategies, through policy strategies. This shows you some of the things that are happening that are changing the epidemic, that are changing food and physical activity behaviors at a population level. And it's really exciting to see. And we see that actually rates of obesity are decreasing, and in many populations, they're flat or even declining. But for many subpopulations, particularly racial and ethnic subgroups, those rates are still climbing, they're still too high. And we see that particularly for African American girls and Latino boys, rates of extreme obesity are actually increasing at a very fast clip. So we're very, very concerned about it. And from an equity standpoint, from a social justice standpoint, we can't look at the average. We really have to look at the subpopulations and see what's going on there. So let me go back for a second. Just to give you kind of a little bit of a perspective on what we can do to really change things like obesity. I want to just reference briefly a couple of great public health victories, and just to give you a flavor for the kinds of solutions that can be brought about here. Lead is a great story. In the late 60s, we realized that about 12-15% of our urban populations were subject to lead poisoning. And we treated this as a healthcare system by doing better screening in our doctor's offices. We identify people who are at risk, we screen them. When they screened positive, there was chelation therapy to remove the lead from the blood. Then we kind of started experimenting with some public health approaches and said, all right, instead of treating this one at a time, let's do some outreach. Let's kind of let people know that they might live, if they live in substandard housing, if the paint's chipping, kind of give them a chance at prevention, kind of protect their kids from ingesting that stuff. And then we got really smart. And in 1977, Congress passed a law that got the lead out of paint, that got the lead out of gasoline, and we went to the source. We went upstream, and we took an environmental approach and removed lead from those sources of exposure. And similarly, and we saw incredible results. So now we have less than about 3% of the overall population has lead poisoning. So it's been a huge public health impact with all sorts of benefits to society. And if you go through smoking, similarly, we addressed it with a public health approach. We raised the taxes on cigarettes. We did the Surgeon General's warning. We did social marketing. We made it illegal to smoke in public places. So we took a comprehensive approach to that, and we've seen smoking rates plummet in this country. We've seen the same around auto safety. We've designed cars to be more healthy. We've done a lot of work around drunk driving. We've seen driving fatalities go down, and on and on. So we've had some really major success in a lot of these areas. And I just wanted to kind of end with kind of making some connections to some other things. So I don't know about you, but when I kind of go to sleep at night, obesity isn't the major thing I'm kind of worried about that keeps me up at night. I mean, there's a lot of work to do there. You know, there's some other issues that our country is struggling with. We're worried about climate change. We're worried about the state of the economy. The thing that I love about public health and that I would love to infect you with is that a good solution solves many problems. And I think the great opportunity for public health is for us to get in the middle of all these, like the biggest, juiciest, most wicked problems and address them simultaneously. This is the island of Kiribati, which is halfway in between Hawaii and Australia. And all estimates say that this island state is going to be underwater in 50 years. So, and because of greenhouse gases and rising sea levels. So there are a lot of places that are incredibly imperiled. This is just one example of a lot of the developing world that is being affected. And those are mostly people of color, people that are very poor, that are getting washed over by climate change. And what are some of the big drivers of climate change? Industrial agriculture contributes 20% to greenhouse gases. So the way we grow our food, the way we shuttle it around all over the world, fertilizers contribute 20% to greenhouse gases. Transportation, and in the industrialized world, cars and trucks and the way our land is spread out so that we have to drive everywhere contributes 40% to greenhouse gases. So thinking about the connection between obesity and climate change, if we are able to re-engineer our communities so that we could use more active transportation, walk, bike, use the bus more, if we're able to grow our food more locally, more sustainably, we're going to be able to give places like Kiribati a fighting chance. Similarly, on kind of in terms of the economy, you know, so much of our focus is on making sure that people have jobs. And just like violence in communities that are struggling with diseases like obesity, you know, the most important thing, the most important issue is jobs and whether people are, you know, able to put food on their table and whatnot. The good news here, again, is that there's a relationship between the kinds of solutions that are good for local thriving economies and good for obesity. Healthy food is the single largest growing grocery category. It's going up by 20, 30% year on year. Organic food, fruits and vegetables, there's a huge demand. And that means that there's a huge job opportunity for people to work in sustainable ag and local food retail. There's something called the Pennsylvania Fresh Food Financing Initiative that I think you probably know about, sir. Right. So this is an example of an effort by Mayor Nutter in Philadelphia and some state legislators that looked at obesity in Philadelphia and came at it not from a public health perspective, but from a jobs perspective. They added thousands of jobs by bringing supermarkets and farmers markets to urban and suburban Philadelphia, and given people that didn't have jobs before really good, well-paying, often union jobs in the food sector. And the same can be true if we think about active transportation. Building a big highway creates a lot of jobs for a short period of time. If we took that same federal investment that's going into highways and put them into public transit and other things, we could have much greater number of sustainable jobs that could really drive our economies. And the more people that bike and walk through our main streets, the better our local businesses do. So kind of local chambers of commerce are looking at what they call pedestrians as an indicator species of a thriving downtown. So the good news here is that a good solution solves many problems. And I think as people that don't just think about public health, but are citizens that live in a country that is beset by a lot of big challenges, we got to look for these nexus solutions, these win-win solutions. And I think through the lens of public health, we could link up with people that care about jobs, people that care about climate change, people that care about social justice, people that care about economic development, and think about the solutions that are at the middle of all of those big challenges and big opportunities. And I think that's what's really, really exciting about public health, is to work at the nexus of all of these wicked challenges. And I want to close by saying that there's this mindset that I think we can carry with us no matter what area in the health professions we choose. I know many of you want to be physicians and other kinds of healthcare providers. That's cool. I would ask you to consider getting an MPH, thinking about the role that the environment outside your medical office building or outside your hospital plays, and how limited your efforts are going to be if you are not playing an active role in creating the conditions for health outside your medical office building. If you want to be a healthcare administrator, if you want to run a hospital or be a nurse manager or something, that's really cool. I would ask you to think about what are the partnerships that you need to have with community groups, with federally qualified health centers, with folks in the community that you can partner with to address those conditions. Public health is such a ripe area, a ripe field, but traditional public health is limited. And I think the new vision of public health is to think not just about health, but think about the role that economic development plays. How do we address violence? How do we address climate change? And how do you build coalitions and alliances with all these people that have very different goals, very different missions? Health is not necessarily the first thing they think about, but our strategies are completely sympathetic. And we need to build political will in this country between public health and economic development and people that are worried about the environment and all that. And so there's a new set of skills that public health practitioners need to build these kinds of alliances. And similarly with research, there's all sorts of research opportunities here. But most importantly, as citizens, I don't think we can be passive here. There are some really important public choices before us that really define our values and define our future. And I think public health thinking, public health values really need to be manifest in these public choices, like the debate we're having now about the Affordable Care Act and its future, like the sequester, like the federal budget, like how we're going to deal with this debt situation. And unless people like us carry these concerns about the health of our communities into those conversations, we're going to be in a heap of trouble. So I think there's some trying times in front of us, but I think that we have some tools and some ability to really turn things around in a way that will create a brighter future for all of us. So I think it's an exciting future. With that, I want to say thank you. And I think we've got a little bit of time if there's some questions or comments. So thank you. Does this provoke anybody? Does anybody have an opinion? You're all going to go into public health and change the world? Yes, okay, excellent. Thank you. Any questions or comments? Please.
I have a question. In our public health program, something we struggle with is how to blend strategies that successfully combine upstream and downstream approaches, and it's just so challenging. I just wanted your take on that.
Yeah. I think that's some of the most interesting work now. There are a whole bunch of experiments. Where's your?
San Francisco State.
All right. All right. So there's a number of experiments now that are going on that are trying to connect physicians and people that are working on the downstream stuff with public health and upstream work. And the big question is how to align the financing so that the money that's being spent in the healthcare system could be reallocated to address some of these kind of upstream prevention opportunities. And so we see things going on in Ohio and in Oregon, some experiments in California to try and kind of realign the dollars so that instead of paying for diabetes treatment, we can reallocate the money and pay for some of the prevention activities. And it takes public health working together with the healthcare system, and I think we're just trying to figure out how to realign those incentives. There's the Center for Medicare and Medicaid Services, which is the federal agency that is in charge of Medicare and Medicaid, where most of the major dollars goes, has a whole bunch of experiments now called that are looking at reorganizing these payment systems. In California is actually submitting a grant application to try and figure those out. But it's around payment reform and trying to have us figure out how to put the dollars where they can have the most amount of impact. Any others? Please.
What efforts is Kaiser doing on implementing the health and all policies efforts?
Yeah, so you want to say what health and all policies is for those that might not be familiar with it?
For any land use issues or any public health issues, they want to look at what the health implications are on that. So whether it's locating grocery stores, the food stamps, anything to determine the health impact.
Right, so this is a really big idea that actually a lot of European countries have implemented for some time, health and all policies. And for those of us that are fortunate enough to live in California, California is really kind of setting the pace for the rest of the country around adopting health and all policies. All the major state agencies participate in something called the Strategic Growth Council, which has adopted a health and all policies approach that says that before the Caltrans, the transportation agency, decides whether a highway is going to go here, how they're going to use public money, before an employment strategy gets deployed, they're going to think about the health implications of that. And so there is now a formal way to assess the health impact of big state decisions. And there's some really great people in government that are doing that. And Kaiser actually, and a number of others, have provided some of the investment for that council to get up and running and to do some of the health impact assessments for a lot of these state decisions. And there's a number of kind of specific implementations of the health and all policies approach. One of it is looking at climate change and what the implications are, how to drive health outcomes with the state's implementation of their climate change reduction strategy.
Getting local boards to supervise.
Exactly, and it starts at the state level, but a lot of the implementation happens at the local level and at the regional level, and the state transportation, the local transportation agencies, and the people that are responsible for how our land use is organized and what kinds of transportation access we have are often local folks. So that's where the work really is. And it's exciting because that's where people can really make a difference.
Well, on the policy, health and all policies, we were just talking about the poverty and how much of an impact that has. But people that are on welfare are a catch-22. If they get a job, then they lose their welfare, they lose their medical, and then they're the working poor, and they might as well just go back on welfare.
Right.
So
Right.
how do you fix that?
Right, and we know that you're stuck if you're poor. It's really hard. Your job, and you can get a job. The job is often quite a distance away, and so there's transportation issues involved there. Anyway, I realize we're at the end of our time. I'm going to stick around for a little bit. I know you guys have workshops to go to, but I want to thank you for coming today, and good luck in your careers in public health and changing the world. Thanks.